is Cătălin Dogar and I will be your host for today at a special edition of UMFST Live. Here with us we have Professor Jans Rassweiler, a leading expert in urological surgery, professor in urology and andrology at the Danube Private University in Austria, and co-supervisor of one of our PhD students. He has a great career that started in 1982 as a urological education with his urological education. 10 years later, he would come to perform the first laparoscopic nephrectomy. He has been chairman of many renowned urological, endourological, and lithotripsy associations. For his papers, he has been granted many publication awards, and he is Doctor Honoris Causa of 3 of our main historical medical universities in our country. And he is also a fellow of the Royal College of Surgeons in Glasgow. Welcome, Professor.
Thank you very much. I'm very happy to be here. And I must say, as you mentioned already, since I have been elected as Dr. Honoris Causa in several universities in Romania, it's of course a special event for me to be here again in the 4th university that I have now known. And I'm really impressed about everything here, and we had a wonderful session, as you said, with the thesis application in the morning, also the scientific session. I was really very happy with everything, and the faculty was very nice, but we had also very fruitful discussions.
To get us started, I'm sure the viewers would like to know more about who you are and how you got interested in urology.
Okay, I can tell you, it was very interesting because when I was a student, I worked in an anesthesia team to earn money. So I did, you see, as a kind of student already, I assisted the anesthesiologist, and there was a team of anesthetists in Stuttgart. This is my hometown, VfB Stuttgart, and there I went to different let's say hospitals, and there were 2 urologic hospitals among them, an orthopedic hospital and so on, and I said, I will never do urology, you see, because it smelled like this, so I would say no. Then I had a girlfriend who worked in the lab, and I had to pass the Katharinen Hospital to visit her, to take her whatever for out, and I said again, I will never do urology. In exactly this place, I became a urologist so very soon. And this happened because I started in Freiburg when I did my studies in the Department of Radiology work on renal embolization. So we did embolized rats with a certain substance to really get a complete necrosis of renal tumors that we produced in the rat, and also finally in dogs to apply the classical angiographic technology. And this was the reason, of course, we collaborated with the urologists at that time. This was the reason that got my interest in urology. And by chance, my professor has been working in Munich at that time as a starting urology career, but he didn't continue it. And we had now the, let's say, the nice connections to Professor Eisenberger in Stuttgart, namely what I said. And we visited him on our way to my first publication, I can say. This was 1979. There was a presentation of our work at a very big radiological meeting in Munich, and we bypassed Stuttgart to Professor Eisenberger. Of course, we did not present it. The professor presented the work, but we were allowed to go with him. And he was so friendly, and so he said, oh yeah, when you are ready, you should become a urologist. And so I decided first to do my 3 months of internship in urology, or 4 months of internship in urology in Stuttgart. Yeah, and then I was in. And then I started with 1 year of pathology close to Tübingen. And I had a 2-year contract, and after 1 year I got a phone call from Eisenberg. He said, you have to come back now and start.
Were you a technical person? Did you like maths, physics, machinery. Why I'm asking this, because our main discussion will be about robots and technique.
No, I understand. I must say I had to wait for half a year, as a one semester, to get a position as a student at that time. And so what I did was I started physics, to study physics. And I know that at that time it was terrible mathematics I couldn't understand. Physics was really difficult at that time because you have to know mathematics. And so I was quite happy that I got my position as a medical student afterwards. But of course I never lost my interest in physics, and let's say in a more simpler way, like we doctors know it, and we of course did it also then in the studies. And this is always something, you know. For example, when we worked on our embolization, I did some experiments about viscosity. So this is a physical phenomenon, how the fluid goes. And later on, we came to, in Stuttgart, with the shockwaves, the treatment of stones, you know. This is a complete physics topic. How work shockwaves, how disintegrate shockwaves, stones. So this was always nice for me to combine, let's say, physics, natural science with medicine.
The laparoscopic procedures were invented during the 20th centuries. Perfected during these times, and you were one of the leading pioneers in this kind of field. How did your colleagues look at this? Because there's always somebody that stands out, because...
Yeah, you see, I was, of course, maybe retrospectively a bit too, let's say...
Invasive.
No, I would not say invasive. I would say provocative in a way. I tell you the story. I was in 1991, there was the first meeting of the Society of Minimally Invasive Therapy in 1989. I was a founding member there. John Wickham, which was a big guy in stone surgery, and he also did first cases of laparoscopy, and Ralph Kleiman, who did really the first laparoscopic nephrectomy, were there, and Kurt Semm. Kurt Semm is a gynecologist who 1983 already performed an appendectomy, and he was almost killed by the surgeons. So he published this, and really they required a brain CT from him, that he is not sad or whatever, to get this article published. And so you can understand how was the feeling then. It was a little bit better because Kleiman, of course, did the work, and we just reproduced the work the first time in Europe and in Germany. So we were not so alone, I must say. But I can tell you really completely that Peter Alken first said, today we had the thesis, you have to finish your thesis, you cannot work directly. So in 1991, I had my thesis as a professor in the university, and it was a work about this embolization I told you. And as a talk that I had to give were minimal invasive therapy. And what I showed them were the first 6-hour movie, not 6 hour, when we did the first laparoscopic nephrectomy in the porcine model. So 1991 I started. I took a course by the surgeons. They showed us how to take out the gallbladders, and then I discussed with them, and then we got the pigs to try our first nephrectomy there in the animal lab. So it's a little bit like Timisoara. It was in Germany at that time. And so this is the way. And then I tell you, when I saw some scenes of this, I was completely convinced about it, you know. So this is the way to go. And this is the problem when you are convinced about something, and this, as you said, people around you cannot understand this, they don't get this feeling. And so then they don't believe you. They say, he's a crazy guy, and what he's doing, this is never reproducible, and so on. So it was in the beginning, they were talking about a nice procedure looking for an indication, you know, so nephrectomy is not so often, and so now the things have completely changed.
Yeah, in 1992, you did the first, you were the pioneer in laparoscopic nephrectomy. You also published a paper on the radical prostatectomy.
Yes, this was 1999. So we had this experience, and then the French group, they started with the first cases. They did it very well. Not first case, and then they published 40 cases, then 100 cases. So they waited until they had really good results for Montsouris. And I must tell you, I worked at some of these meetings, life surgery meetings, together with Guillaume, who was the co-author, one of the two surgeons. And I thought, I watched him how he was working laparoscopically, and so, and I said, I have to do this. I know that I can do this, because if he can do this, I can do this also. And this is the way we continued. So I saw the videos, and then we started with the procedure. And it was quite interesting. So it went well, and I tried to reproduce the open technique. This is the Heilbronn approach. The classical way, also here in Cluj, they do it starting from the bladder neck and dissect down. Has the advantage that it bleeds less because you control the pedicles earlier, and the open surgery comes from the apex, from the urethra, and goes up the way back. So in the beginning, this was really, you had to master a bit more the Santorini complex. Interesting how things have now changed with the use of robot. Bleeding is no more a problem, transfusion, but at the beginning it was really not so easy, I must say. And this was the approach, and then we standardized this technique. And this is the good thing. You were speaking about people. So you have on one side the people who are skeptic and they cannot understand. But you have the young guys, and they are now getting older, who came all to Heilbronn. These are the fellows from Romania, the fellows from Turkey, the fellows from Greece. So we had a lot of fellows that I trained, and they were always around me. And this gives you, of course, also a kind of feeling of confidence.
So I've read that you have perfected the Heilbronn technique.
Yes, I must say with the as introduction of the robot, I can tell you 2000 already. We had 180 prostatectomies. I had the idea to work with this Da Vinci device. And at that time, there was one Da Vinci device in Germany at the Heart Center in Leipzig, which is a little bit far away, close to Berlin. Professor Mohr was his name. So I went there and I saw them working. And it's a little bit like here in the studio. The device was outside and the surgery was here, and then they were communicating with a microphone, so like telesurgery, which is no more done like this. And then I was really convinced. And at that time, Dr. Binder, he was one of my fellows, training fellows, and he came from Frankfurt. And he heard about this, and then when he went back 2 weeks later, he knew that his cardiologist or cardiac surgeons has also a Da Vinci. So that's the reason why he started with the first radical prostatectomy with a robot in Frankfurt. So this team. And he invited me to the third or fourth cases, and then I said, we have to try to do something. And I got really, could get the device for 10 days from Intuitive. They will not do it anymore, but at that time I was able. We did our 6 or 8 cases. And then afterwards we were sitting together with the guys, and for my former work with the lithotripsy companies, so there was clear, either you get the device and you pay for the parts, or you pay for the device and you get the parts for free. And they were sitting there and said, no, you have to pay both. At that time it was quite cheap. It was 890,000 German marks, I guess, so it would be 500 euros or whatever, quite cheap at that time. But I couldn't convince at that time, let's say my people, the CEO from the hospital to buy it. And so it took me another 7 years or 8 years until we get the device then really. And this was exactly what you were mentioning. Then I was really able to perfectionize a bit more, because you had the 3D vision, you had, let's say, the movement of the arms, you had even a better magnification of the anatomy, and of course we are working on this. I think one advantage of laparoscopy in general and robotic surgery is that you are dealing with the anatomy, and you reinvent the anatomy. I would say it's not completely clear, but the anatomy is completely different. It's a microscopic video-assisted anatomy rather than this open surgery with a finger and doing something. And this is what makes things better, because then we analyzed a lot of papers. Today we had the discussion, how can we improve early continence of a patient? So then how we have to functional length of the urethra to protect the nerves and these things. And that's what I could
conservative.
say. It really, yeah. It's an improvement. It's a next step. You improve always what you do.
The paper that I read was about 500 oncological patients. What were the results of?
At that time,
500 is a lot of people.
Exactly. At that time, we were happy to prove that we were equivalent. So it was a kind of retrospective analysis, as of the last
Yes,
that
what
we
about
did open
now?
and the next part. It was not a randomized trial. But I think until now, it's really difficult to do a randomized trial with a new technique, because you have always a different level of expertise at a certain time. And then when it's through, then nobody of the patients wants it anymore to be operated in an open way. But anyway, we were able to prove that we were equivalent with our results, positive margin rates and all this thing. And I think this is up to now. I would not say that robotic surgery is better oncologically. I think not. I think if you do a proper open surgery, you do the same thing. But the functional results are better. You have less strictures, no bladder neck contracture. You do a nice anastomosis. You do not down. You see, you don't see the and do the anastomosis of the bladder. So you pre-stitch it. So there are a lot of technical steps which are simply much better. You have less transfusion, shorter hospital stay. All these things are very important for the patients. And that's why I think, and the functional results, early continence are better. So I think are the main advantages, and that's why people now really go, also the doctors now, at least in Germany, so tend to have a robot, as it goes the other way.
What were the biggest challenges that you encountered as a urological surgeon, and how did you manage to overcome them? Mm-hmm. It's been 40 years since the beginning.
I can tell you a cava thrombus is always a challenge, and I have not done it like others with a robot or so. I did it by open surgery still, because I would like to have a certain hand on it, because it can bleed like hell. You see, you have to really get all the veins, and it's just sometimes you have to dissect below the liver so that you get the upper part of this thrombus. And you know, if you don't get this, then the thrombus may go to the lungs, you know it, and then you get a kind of infarction and things like this. So this is really always a challenging situation. And what I think is we discussed this now, what is necessary to become a surgeon in this way. And you are no more trained in the open surgery. You have to have this mentality, probably you know it, to master such situations. So you have to be calm, and it's afterwards you are totally down, but at the actual moment you have to be calm and do the right thing. And this is probably not for everyone. Not everybody is able to do this, so they're starting to shiver or whatever.
Maybe your first one was that.
It's the first one were always took longer time. I would not say that I was shivering. The shivering situation comes sometimes when you are really
adrenaline
under
rush.
press. Exactly, when you have this rush. And then of course if you sit at the console, then it's nobody noticed this because you have the transmission. But in open surgery, sometimes I must say this can happen, of course, yeah. And we are in urology. You see, it can bleed like hell in the pelvis sometimes. So these are really the things you have to then manage in a certain way. You are close to the big vessels, to the aorta vein. And this is probably, the acute hemorrhage is for me really always a challenge, really a challenge.
How does somebody become you? How would you advise the young residents, young specialists to?
This is interesting. Because of course I'm a dinosaur and I'm still convinced about, let's say, the generalism in urology. So I would not recommend him to focus just, let's say, on robotic surgery. So like in the States or something, or even Patel, one operation, radical prostatectomies, 10,000 I have, as he has done, yeah, nothing else, of course, optimal results. I don't think that this is urology in a way. I had the chance that, let's say, with my interest throughout the years, I went through all these things. I started with ESWL, with endourology, then came laparoscopy, then sometimes came oncology.
So there are the stages,
I had all the stages, you know, so, and I had the time, of course, because I was always in the developmental phase to establish this. Now, if you are here and then you have to learn all this, it's a lot of things. But on the other hand, you are no more a pioneer in this field, so you can just take it over. And you can benefit from the, let's say, from the robot. You can benefit from the small ureteroscopes, from the flexible instruments, and so on. So you have, as a young guy, you have more chances to transfer the technology and really get involved in it. So I would say you should be really fascinated about urology as a topic, general. This is number one. You have to have maybe a little bit, if you want to stay in the department as a clinic, not go to the office urology, have to be a little bit more patient with yourself, as the way what you do. And now I don't get the operations, I cannot do this. So you have to find your way, and you have to be sometimes to take your own decisions. Because sometimes I notice this now with my fellows, next generation. I said, come start. Yeah. Oh, no, I want, please help me. Also stand by me. Yeah, so they stand by me. I must say my daughter is a urologist, and she did also a thesis 30 years after myself in the main lecture hall where I presented my stuff, I told you. So I know about her, and here she has 2 children, so she was two times 1 year out with the first and second child. And I know this, she's always complaining, you see, I'm not doing this. And I said, be patient, yeah, you have to have your time. You had been 2 years out, so take this into account, and things will come, you know, so you will go far and far. And I think this is very important, not because some people are very talented and then too early they turn away and say, oh, no, this is not for me, or I focus just on this.
You have debates during dinner, or?
Yeah, I don't know, but at least you must have a kind of silent in yourself, because things are really coming. It's also, you see, so sometimes, as I mentioned, you may get cases during the night shift. You see, it's not like, how many patients I had during the night shift. You can also say, yeah, I was able to place this and this and to do this and this during the night shift. So it's a kind of, let's say, how you are, the enthusiasm that you have. You need this. This is the only, also to become like me, you need the enthusiasm about the profession, about the science, about the technology, about the surgery.
While I was getting prepared for this, I read about all of your papers, and I even got to ancient Egypt about gallbladder stones, about urology stones, about kidney stones, and they were using all sorts of techniques. So techniques have evolved during these years. You were a part of this, and now your daughter is part of this. So she has the enthusiasm that you had maybe, and now maybe you will contribute to something new through her, maybe.
This is one thing. I'm quite happy about this.
I'm sure you're proud.
And on the other hand, you see, for example, today I was talking, and we discussed it a little bit about this, as you said, ancient medicine and so.
Yes.
You know, we started with ESWL, destroying stones. Now we have ESWT therapy, and we can stimulate stem cells by this. Also, you know, I had a Fournier gangrene. I published it just now, and I treated this only with shock waves, and it closed the wound very dramatically in a way. And where scrotal tissue was, is scrotal tissue, and where penile tissue was, is penile tissue. You know, so it's different. You know, and just by healing. So you know, and this is it's a non-invasive therapy. And we will talk about magneto-transduction therapy in the future. So you know, the capabilities that we have in the future generation are also continuing. So you see, and this is something, maybe we come to ideas that are, at the moment also people think, are you crazy? You use magnetic therapy? It's like, you know, you like magnetic stone put everywhere. So, but there is a technology and the science behind it, and even with the shock waves, this is very fascinating. This is, for example, what fascinates me new, and this is what I see, as you said with my daughter. So the next generation, it will continue, and it will probably come closer to non-invasiveness. You know, so like the
Hippocratical.
Yes, exactly.
Yes.
Yeah. Don't cut for stones. Maybe you can dissolve them, or you treat them from outside, or you go endoscopically. At least don't cut.
What do you think the future brings for urology surgery or for medicine in general?
Yeah.
Is technology something that we will need to use, but energy is more expensive and more expensive at this time?
This is something probably, I think we have to see this also on a global way. And it's clear that we are producing, let's say, particularly in Central Europe, a medicine that is beyond what you could do probably in Africa or in other places. So we have always to think, how can we use our technology to help them there, also to provide the medicine globally. And this is something which is probably a very important task, because on one side we have to improve the techniques and the technology. This will continue. It has become more difficult with this medical device regulation for the companies. So we will not have this boom and this easy, just I try it. So you have always a lot of, let's say, administrative work behind and investment for these studies and the maintenance of all these things. So this is not in favor of let's say, technical development, but we had bad experiences with the breast implants and things like this, and so I think it makes sense. But it's not what I really like always. But we have to think about this. And on the other hand, we have maybe the limited resources. We have to see what is the best way to go. Sometimes maybe what is the cheaper way to go to do the same thing. I'm really here also. It's not always the medicine, but one thing, and this was an argument this morning also. You know, all the costs of the new robots and the costs, and we need to have more money in urology. Those devices, those clinics who invested in a robot, at least in Germany, but we have not it's not a private system here, so they did not get bankrupt. So it went through. It was just the right investment at the right time. I think this is the thing. And so I would really say we should not blame the new technology, the robotics, always by cost. Let's say, talking about here the thesis about, let's say, artificial intelligence improving MRI imaging. And then you know that you have not to treat, let's say, 20 or 30% of the patients. You can say they have either no cancer or indolent cancer, prostate cancer. And I biopsy only the rest. So then at least 30% benefit from it. And it's also costs to do a biopsy and all this. And it's good for our patients, and we do less than more. And so we should really use our technology and invest in things in the right way. Of course, not beyond everything. This is clear, I understand this, but we have to do our right investments.
Because you are a pioneer, you got to do all the hands-on things that a pioneer does, but now what do you advise the young specialists and residents to do to improve their skills?
They have good chances now, because we have optimal training programs inside EAU. We are starting. We have the master classes, which I don't have in a way with hands-on. They have models, so they should use every facility, let's say, of the simulation training that they are really good. They should go into it. You see, it's not good. I want to do a surgery and my first TOR, and then I go in. Can you put this device together? oh no, yeah, so like this, yeah, it happened, yeah. But I want to do my first year, and I have no idea how this thing works together, because always it's there, the nurses are doing this, and I said, no, I put this out, please, before you start to do it. So that's what I mean, yes, you need to have now it's so easy to learn a lot of these technical things, and then you get a nice basis, and then you have to find for yourself a kind of research field which you like. So as I mentioned, at the moment, one of my last, let's say, PhD students, so he's a good bass player, by the way, he did his thesis on brachytherapy. Now he is in Mannheim. When I left SRK in Heilbronn, and I said, ESWT, this might be the next work for you. So maybe he will go into this, because I see a lot of research fields in this regard. So we have to look, it's there.
Because we are a newly formed university with a merger from a University of Medicine and Pharmacy with a Technical and Sciences University, I always ask these questions from the people that we get invited here. Do you think it's a good idea to mix medicine and technology?
This is what
it's almost a rhetorical question, but I always ask this from all my guests.
If you ask me, yes, a clear yes, and I think my life.
We have skeptics.
I know, but I know. But if you take my life, it shows you that it works.
Enough about shop. Let's talk about passions, because I even found something about you, about your hobbies on PubMed. I found the Uro band on PubMed. I couldn't believe I found something else than your urological things, urological operations and everything, your innovations, but I found something that's more particular and more to the soul. Like you are a guitar player, and I even found a video on YouTube with you playing. I think you were singing maybe at that point.
So there is, for example, this is a story that started a little earlier.
So you can do your passion also, no?
Yeah, this story started, of course I played a long time. I played also let's say during the student time, even when I was an athletic, as I was training in the training camp, I had always my guitar with me. So this has a long story. But then, let's say with urology, it started with Kurt Miller. This was the former chairman of the Charité. When we were still in Stuttgart, we did a song at the party, at the Christmas party, about the clinics, what is happening. And at that time, we just took classical songs and put lyrics in it, also in German lyrics about you or the other guys, you know. And then when I moved to Mannheim, then it was a specific moment, because we had 3 or 5 people are fascinated, one bass player, guitar player, and so on, drummer. And so we met there in the night, and then we started with the urology songs. Then we had 2 young guys, as one young guy was the most. He came all the day with a new thing. And we started, our first song was the Shockwave Killer. This was the machine, the modular device that we developed with Storz Medical. This was a new lithotripter. And this was a maxi single. And this was about 30 years ago. And with this maxi single, we presented first time a kind of 8 songs, 10 songs at a meeting, at the Southern Section meeting. And there was one, this is what we heard. This is the Southern Euro Blues. This was my composition, more or less, with a harmonica and singing. And this is what, when we promoted, we did this for the first time, and everyone was happy about this. Then we were able to produce every other year, more or less, CDs. So we produced 6, 7 CDs. That's why we became a kind of historical part of urology. And so in this year, when I was president of DGU, I discussed it before, but I took the right to write the history of the Mannheim Euroband. And this is what you found now. It's published, of course, in Urologia, but it's more a historical paper about urology.
Yes, but all in all, it was interesting to read.
And this was really, then you see the CDs that we had and the shows we have been in at a certain time. And we are still playing. Also, we had now 30 years after, in the same city in Koblenz, this was in May this year, we had the same concert. As it was the concert of the of the Euro band. Not always the same people, 3 are the same. It's like with the Beach Boys, 3 are the same, and others we joined us. But we did rehearse the old songs again. And it was really a fantastic evening there. And we are, as I tell you, we are still playing, we are still active until now.
So it's possible to have hobbies and be great at your job also.
Yeah.
Yeah, you are a great role model for.
This is exactly. I think this is important. You have to do. You have always. Of course, you see, music is a thing
to calm
with,
you down,
with enthusiasm, and also there, to improve yourself. Now with the YouTube videos, you see, in the beginning we were listening to the solos of Clapton or so. Now you go to YouTube and see how he plays it.
Only go on Google and you will find the
tabs.
Yeah,
exactly. Yeah. But the tabs with the videos is even much easier. So tabs were the next step. Yeah, you could find it. And so this is exactly why I think so. So you can improve significantly now with the technology that we have. And of course, music is not just playing some solos or things. Music is this interaction between 2 musicians, for example. And this is unbeatable. You see, this is when I play with my friends, or I have a specific guitar player. I play every other week, I must say. And sometimes we are just floating, so it's just so jamming a little bit. Not you have to do this, and then you create things. This is unbelievable, and this is exactly this feeling you have to get as a musician, and in this way, and it must not be perfect, but it must this vibration, you can say.
I'm sure that it even enhanced your dexterity of the fingers because
it's clear.
You need them.
Yeah.
As a last intervention, I would like you to say something like an advice for young urologists, because it's something like we need to look to the future, to the young urologists, and they need some guidance. And because we have you here, I'm hoping that you will give them a message and also talk a little bit about the future of urology.
I think the future of urology is bright because people are getting older and we will have more and more people to treat. So if you become a urologist, you have work, 100%. Urology is one thing that you can be a surgeon. You can even subspecialize in endourology, depending on the different systems. You have in England or so in the States. Even in Germany now this may happen. Then you can go into private practice or office urologist if you don't like it. You do oncology, at least we in Germany. So you have andrology, you have a very bright field. And this is, I think, more or less unique because you see, if you let's take neurology, there's a neurologist and a neurosurgeon. And we in urology, we are urologists and we can say neurosurgeons. So we take everything until even transplantation. Of course, this is going down a little bit. But you have this wonderful field. You have the bright future. So the next thing is you have to take all the chances that you get for education, which are really enormous, and I must make some advertising for EAU, because I'm also board member of EAU, and we do a lot, we create with the sections, with everything. So this is one thing that you don't stay with you, so you have to spread out, you have to network, which is, I think, today also easier. And then you have to go out, to see other things, where are they doing this? And then finally, if you are lucky, then in your, let's say, personal field, you can then bring things back and hopefully find the resonance. This is something, the mentors, So, but I guess, particularly in Romania, when whether this be Dr. Coman, it was Viorel Bucuraș, unfortunately died in Timișoara, and all the guys I have, Simonescu, I think there are a lot of people who are open for this. And let's say Cluj, it's not so far away, So I have a lot of these fellows there, and they came back and they do a and here also he do a good job. So that's what I think. So you have to take benefit from it.
Networking is-
And networking, this is so important.
Thank you very much, Professor, for all this wisdom and for accepting our invitation. And
I'm thankful to be here, and I really enjoyed the interview.
I'm glad you made it to our Congress also here in our campus. I hope you enjoyed the campus. It's a little bit under construction right now because we are trying to improve it, but
It looks good.
I'm sure. That's all for today, and I hope you found our discussion interesting and you will join us again. Best wishes to everybody.